Hi, my name is Marianne Hart. I'm with Indiana University Research Metabolic Bone Research Group, and I'm excited to say that we're here to provide short educational series, short videos for you to provide some education on topics of rare bone diseases that we work with here at Indiana University. So over the next couple months, we hope to be able to provide short videos that will give you some education and maybe help explain some of these difficult topics. So these will be provided by experts in metabolic bone from not just here at Indiana University, but other universities across the country. We're going to start this week with a series on osteopetrosis and go over the types of osteopetrosis. In the future, we hope to have other discussions on osteopetrosis, like the genetics of osteopetrosis, or a deeper dive into the genetics. We will hit on genetics today, but also talk about osteopetrosis effect on the bone, and some other things. If there's something that you would like to hear us talk about, feel free to send us a note either on the Facebook group or through our email, and I'll share that information at the end of the presentation today. We'd be happy to take your suggestions and do what we can with those. A couple of disclaimers. If you want to go to the next slide. This information is for educational purposes only. We do not intend for it to take the advice or care from your personal health care provider. We cannot provide medical advice. If you have questions, generic questions about what we present today, that's great. We'll do our best to try and answer those questions. You can send us an email or leave a post on the Facebook. But please, as a reminder, don't post personal information, health information. We will delete it, and we will not address specific medical questions about a specific individual. So never a good thing to post personal information. So that's kind of those kind of things. At the end of the presentation, I'll talk about where you can find more about the information that we're going to discuss. Today's discussion will be led by Amy Katz. She's a research coordinator here at Indiana University in the Division of Endocrinology and Bone Disorders. And then she will be talking with Dr. Michael Econs. He's a distinguished professor here at Indiana University with the Division of Medicine and Medical and Molecular Genetics at Indiana University. His research with rare bone diseases goes back a long time. And we're very excited about his willingness to spend some time with us talking about osteopetrosis and help bring this information to you. So without anything else, Amy and Dr. Econs, I'll turn this over to you.
Great. Thanks, Marianne. So want to just kind of dive right into this. Dr. Econs, I know from learning about osteopetrosis that there are really two different types of osteopetrosis, one specifically being autosomal recessive osteopetrosis and autosomal dominant osteopetrosis. But let's first focus on autosomal recessive osteopetrosis, which is also called ARO. Can you give us a description of what ARO might look like clinically?
So thank you, Amy. The recessive form of osteopetrosis is typically thought of as the most severe form of osteopetrosis. And with the severe form, children are typically born with very dense bones. They have fractures very early in life. A large percentage of them are blind due to the hole the optic nerve has to travel through entraps the optic nerve and can cause blindness. It is caused by mutations in a number of different genes. You have to, for the recessive type, you have to have two mutations, one each from your mom and your dad. To make a long story short, the current therapy is bone marrow transplant. And again, these children will have many, many fractures. More recently, it has been aware that there is a somewhat attenuated form of osteopetrosis. It's not as common as the severe form of the recessive osteopetrosis, that is. And this is probably due to less severe mutations in those genes. It's the same genes, but some of the mutations will allow the protein that's made by the gene to actually have some functioning. And while the severe form of autosomal recessive osteopetrosis, the children typically, if they don't get a transplant, don't survive past childhood. In some of these situations, these folks have survived well into adulthood. And so the disease is different. This, again, is less common in terms of the recessive than the severe recessive
Sure.
form.
So it sounds, and you mentioned some things to be concerned about pertaining to a child who has, ARO. And are there other specific triggers in terms of signs and symptoms that you haven't thus mentioned?
These children do have more infections than other kids, and obviously fractures, blindness. It somewhat varies on which gene is mutated. So the most common mutations are that of the proton pump, which is about 50%, and then the chloride channel. I don't know that we want to get into too much detail
Sure.
about those different mutations.
Yeah, that was a nice segue into kind of how, what kind of testing, is typically used when making a diagnosis. And so it sounds like obviously genetics play a role into that, but there are other tests that you use to make a diagnosis of ARO.
Yeah, typically the diagnosis is first found when plain X-rays are done for the child, and the bones are very, very dense, and you can see a fracture. And so the diagnosis is typically made just from plain X-rays. It's fairly
Okay.
obvious that these bones are abnormal. And then it does pay to find out what gene has the mutations, because that affects the kind of therapy that we do. And again, I don't want to go into too much
Sure.
detail, but the vast majority of osteopetrosis are what we call osteoclast rich, and those are amenable on the recessive side to bone marrow transplant.
Sure. And it sounds like you mentioned the big thing behind the genetics of ARO is that both parents have to carry that mutation in terms of genetics, right?
Correct.
A kind of follow-up question to that is, what exactly are the chances that with each pregnancy that a child may have ARO? Do you know that?
By classic genetics, and this is kind of classic genetics, if each parent, because they have two copies of each gene, one of which has a mutation in it, when you have two parents that have one copy each, 25% of the time, the child will get both mutant copies. 50% of the time, they'll only get one copy, and they'll only be a carrier. They won't have signs of disease. And then 25% of the time, they won't get either mutant copy, and they won't be able to pass it on. Now, again, these are rare diseases, so being a carrier is not as much of a concern as it is for example, in the dominant form.
Sure. That's great. And I'm glad that we've kind of been able to give a really brief overview of ARO. And I think let's talk about these same questions in the context of autosomal dominant osteopetrosis, which is also called ADO for short. So can you, again, kind of give us a description of what ADO looks like from a clinical perspective?
Okay. And I might mention there is an X-linked form, but we're not going to discuss that today. But the dominant form is much more variable than the recessive forms, and it's variable in terms of its severity. So in a dominant disease, classically, if you have the change or the mutation, you get the disease. However, as we'll see in a slide, That's not always the case with the autosomal dominant osteopetrosis or AD02. There was an AD01, but it's no longer considered an osteopetrosis. So we're stuck with this nomenclature. And so many times, although some children will present with osteopetrosis, also called marble bone disease or Albert-Schoenberg disease, some will present with fractures and abnormal x-rays in childhood, but many of our patients only present in adulthood.
Mhm.
And some never actually get disease. The most common problems with autosomal dominant osteopetrosis are fractures.
Mhm.
And of the people who have the condition, the vast majority, by the time they're adults, will have some fractures. Some have very few, and some have over 100.
Right. So it sounds like a big spectrum in terms of that
Right.
kind of first signs or symptoms and when they appear, right?
And in the folks, correct, and the folks who have the more severe forms of the dominant, they will also have things that occur in the recessives. We didn't mention bone marrow failure, which occurs in the recessives. Rarely can occur in the dominant form of osteopetrosis. Similarly, blindness can occur in the autosomal dominant form in children who have a more severe form of the dominant form. I know that's confusing because the dominant form is frequently wrongly thought to be the quote unquote benign form. And I dislike that term because many of the patients with autosomal dominant osteopetrosis or AD02 have severe disease.
Sure.
So I don't like to use that term.
Sure. So
Go ahead.
so I was just going to kind of, talk about the types of testing that you would use when making a diagnosis. So is it similar with ARO, or are there other factors?
Typically, patients are picked up by x-rays.
Mhm.
Then there's several tests that we do after the x-rays, after we establish the test. The vast majority of patients with AD02 have a mutation, a point mutation, which changes an amino acid. And but it's in the chloride channel 7 gene. So the vast majority of these mutations that cause AD02 are just in the chloride channel 7 gene. So we will frequently do sequencing of that gene to determine if someone is at risk. But again, to determine if someone is affected, we frequently will get x-rays, and we'll follow it up with some biochemical tests and also some blood counts to see if they're anemic or having other problems with their blood.
Sure.
In work that we'll talk about in other videos, we have typically a multi-specialty team take care of folks with this disease, including ophthalmologists for the kids who will be watching and to see if their vision is at risk.
Mhm.
Because there are things that we can do to save vision in these
Sure.
kids.
So can you, very simply explain, I know we discussed that we're going to go into a different educational segment on the genetics, but, what exactly, we talked about having both parents having to have the mutation for ARO, but can you very simply explain the genetics behind ADO?
So in classic genetics, a dominant disease, if you have the mutation, you get the disease. However, and I joke sometimes that I couldn't teach high school genetics because that's not completely true. And there's something, and these are really difficult concepts for both patients and physicians to understand. And I'm going to show it via some x-rays. And so what penetrance means is that someone who, there are some times when penetrance is not complete. So if we look at this x-ray here, you can kind of see that this person has very severe osteopetrosis, this woman, and she has a hip fracture. This is the other side of her hip. Notice that This bone is very fractured. And she had a daughter who had a 50-50 chance of getting her mutation. And the daughter had no evidence of disease whatsoever. Her bone density was absolutely normal. And unfortunately, the daughter was told that because she didn't have the disease, that she couldn't have children who had the disease. And what happens is that the disease penetrance is only about 2/3. So that even if you have this mutation, and obviously this woman and this woman have the exact same mutation because she inherited it from her mom. But 1/3 of the time, people with the mutation have absolutely no evidence of disease. And that's called incomplete penetrance. And it's very difficult for both physicians and patients to understand this. To make things even more difficult, the disease severity is highly different. So this woman had 3 children. These are 2 of them here. And you can see that this boy has moderate disease on his x-ray. He has a classic x-ray finding that one sees of these, what they call sandwich vertebra. And his brother has much milder disease here, okay? So you can see all of these people, and we knew this even before we knew what that the chloride channel caused this disease, because we knew they were all related, and these 2 got it from their mom, and she got it from her mom, and she actually got it from her mom. So one of the things that we knew here was that not only can you be a carrier when you have this mutation, but the disease severity is very, very variable, even within the same family who everybody has exactly the same mutation. And this is a really hard concept for both patients and physicians to understand. And even when I say this, people don't really fully grasp it. And except for the people who have large families, and in each large family that we've looked at, we found both people who have severe disease and people who are carriers. Now, these folks would have a 50-50 chance of passing it on to their children. And their children could either be carriers or mild, moderate, or severe disease. Just because you're mild doesn't mean your kids are going to be mild, and just because you're severe doesn't mean your kids are going to be severe. And that's, again, a very, very difficult concept for people to understand.
Sure. And kind of, again, going on this line of difficult to understand and these, different nomenclatures in terms of this of ARO and ADO, could you possibly clear up any confusion about, some of those terms seen in reports, specifically the intermediate phrase? Yeah.
Sure. So in the past, and it's certainly in the medical literature, the term intermediate osteopetrosis has been used. And I don't like that term because it's really a mix. So some of the people who had milder forms of recessive disease, and some of the people who had the more severe forms of the dominant disease were lumped into a category called intermediate osteopetrosis. But since these aren't the same diseases,
Right.
I don't think that's a good way for us to think about osteopetrosis. And we've really trying to get our community, our physician and scientific community, away from that concept. And really figure out what the patient actually has, whether it's a single mutation in the chloride channel or whether it's 2 mutations in about 10 different genes that cause the recessive.
Sure. And a follow-up I have to that is, what is exactly the difference between ADO versus ADO2? I know you maybe briefly talked about that, but
yeah, so ADO2 is sort of redundant because there's no ADO1 now, because ADO1, autosomal dominant osteopetrosis type 1, really has been classified as not a disease, and it's really termed now high bone mass.
okay.
And people with that don't seem to have problems. Osteopetrosis, by definition, is a disorder that affects the osteoclasts, which are cells that dig tunnels through bone to resorb bone. And all osteopetroses are caused by osteoclasts not being able to dig their channels through bone, which is thought to be a self-repair mechanism.
Okay. Thank you for clearing up, you know, those definitions and nomenclatures kind of moving forward through these series and better understanding, you know, the bigger picture of this.
Oops.
Did you have another slide? Marion, you're back on.
Hi, Amy, Dr. Katz.
That sounds good.
Dr. Katz. Amy and Dr. Econs, thank you so much. That was very informative. Even I've been here for a long time and I still took notes. I learn something new every time I hear these presentations. So thank you so much. In the rare disease population, knowledge is power. Patients are often struggling to find a doctor that can understand what's going on with them. So the more we feel like we can bring education to patients, the better everyone will be. If you want to see kind of some of this information in written form, you can go to the OPITS website or the Osteopetrosis Society, and the website is found there. You can follow our group on Facebook, which is probably where you're seeing this presentation. Hopefully we'll be able to keep updates going through that Facebook group, provide further educational opportunities and research opportunities as they become available for diseases within rare metabolic bone diseases, as well as some other things. We want to acknowledge Dr. Linda Polgreen and Dr. Eric Rush, who assisted with putting the information together that is on the OPITS website that goes over these different types of osteopetrosis. Again, if you have questions, feel free to leave them for us on Facebook, or our email address is also at the beginning. It's iuindo.iu.edu. Hope to have some more of these presentations out in the near future. Again, please don't post any personal information either to our Facebook group or directly to us, as we cannot provide medical advice. If there's anything else from you two, any closing words?
Thank you for listening. Yeah.
Thank you for listening, and recognize that you're not the only person out there who has osteopetrosis. I think one of the tough things, it's improved a lot over the years now that we have web access and things like that. But one of the really tough things about having a rare disease is that not very many people know about your disease. Most patients with rare diseases, osteopetrosis included, have gone from doctor to doctor to doctor, and many of them have been misdiagnosed. That's kind of normal for rare diseases. And I know it's a very painful process to be misdiagnosed, but unfortunately, there are 7,000 different rare diseases, and none of us can know about all of them. And so be a little charitable to your doctor, but do get involved in the OPETS group. Recognize that most people who join these groups do tend to have more severe disease because carriers typically don't join, but recognize that there's a wide spectrum of disease, and that your child or yourself won't necessarily be like someone else. And be optimistic. We're very actively doing research. I just spoke this morning with someone two people who are working with companies to bring therapies out. We're doing natural history study, and my group is also doing mouse work to find new therapies for this disease. So we're very optimistic that we will have therapies in the not too distant future. And stay posted with us, and as these things become available, we'll let you know.
Thank you, Dr. Econs. Everyone have a great day.
Thank you all.
Bye.
Bye-bye.